introduce you to today's speaker. Ralph has more than 20 years of experience in healthcare finance, leadership, reimbursement, and operations. He began his healthcare career as a hospital CFO for a 49-bed hospital with a 116-bed nursing home. Ralph enjoys providing innovative solutions to the challenges in today's healthcare environment. He assists providers by developing solutions focusing on cost report reimbursement, charge master development, billing compliance, operations leadership, organizational structure, process flow, board education, licensure status, and EHR incentives. Ralph is a frequent presenter and lecturer on emerging healthcare topics at state and national conferences for the Healthcare Finance Management Association, American Institute of CPAs, National Rural Health Association, and State Hospital Association. Now I will turn it over to Ralph.
Okay, thank you. I, again, appreciate the opportunity to get to visit with this group for the second now of 3 different presentations that we're going to do. Earlier we spoke about the strategies, looking really more at just the financial indicators, and now what we're going to start talking about today is, how do we improve those indicators? How do we start to prepare ourselves for this transition by strengthening our financial position, our bottom line, and everything else as we move forward. So between today and part 2 of this piece of it on Friday, we'll be talking about how do we improve the financial viability by increasing revenues and expenses, talk about monitoring, improving quality, talk about better data management skills, and then how we access ongoing education, which is going to be very, very important. And then finally, how do we enhance value? Because that's what we're all talking about at the end of the day throughout this whole process is how are we going to enhance value? So today, a good chunk of what we're going to be talking about, almost the whole thing, will be just on how do we increase revenues? How are we going to strengthen our bottom line? So we go back to the financial indicators we had. The majority of things that we're looking at rely on having greater increased revenues or decreased expenses. When we think of how do we get better days cash on hand, how do we get a better margin, either operating or total margin. So we're going to focus a lot on that component today. And so we get to that first top priority. And this one's a challenge for a lot of providers because it's not easy. Healthcare in the past has not been easy, and we know as we look at changes in the reimbursement models that are coming through with healthcare reform, everything we're hearing about, it's only going to get tougher. But we have to accept that we still have to make some changes. So really what it comes down to is that for any of these things to happen, we have to have accountability. And it's accountability of who is going to be assigned to an item, and then are they going to accept that accountability. Assigning it without them accepting it isn't going to get us there just on its own. And then finally, no excuses. It's going to be really easy through all of these changes to be able to say, well, it's not easy, it's hard, we can't do it, we're different. All those different excuses or explanations that we receive. But at the end of the day, that's not going to pay the bills. So we're going to have to understand we're going to have to make a change. We are going to have to improve. We're going to be held accountable for that. We have to accept that, and we can't make excuses. Otherwise, our communities are going to be rewarded with less services as we begin to dwindle and perish in the local communities. So we're going to talk a lot here, like I said, about improving the overall revenues. So as we look at the strategies here, what do we need to be working on? It's working to how do we increase or at least maintain. And we'll talk about that in 3 different areas. One is physician relationships, why they've been important in the past, why they're even going to be more important in the future. We'll get into volumes, and we're going to change how we look at volumes going forward, but we're still going to have volumes. And then ultimately, we're going to talk about the revenue cycle. That's that hot topic out there about everyone saying, oh, you got to manage your revenue cycle. If you had a revenue cycle review, what's going on there? We're going to have to work on managing that component along the way also. So we'll start with physician relationships. As we move into a value-based and population-based reimbursement model, no matter what it is, if it's going to be bundled payments, if it's going to be an ACO model, if it's going to be something where we're worried about readmission penalties, which we don't have yet in critical access, but we do in small PPS, what are we going to, what are we going to need? And it's going to be physicians. And we're going to have better relationships with them so that we're more on page with them. And so as we look at physicians, we need to understand that that doesn't mean they all have to be employed. Okay, so the physicians I'm going to be talking about in this arena are those that we have employed. They may be physicians that we've got contracts with, maybe contracts for full-time, could be half-time, could be, down to the definition of a visiting physician where they only come once a month, a couple times a month, as needed kind of a basis. And then we may have other ones that are freestanding. Now, we don't see as many freestanding in the rural markets anymore. However, there are pockets of the United States where freestanding physicians still thrive. They're very independent, but we're going to have to be working on those relationships too. And the reason that this is going to be so important is that in the past we can argue that they've been important because people don't choose to come to our hospitals. They choose physicians. And physicians ultimately are the ones that typically are the ones that are deciding where a patient is going to go. So if they need service A, the physician can say they're going to go to your facility or they're going to go to another facility, and the patient is typically going to follow that. They don't pick the hospital itself. And sometimes we don't understand that as well in a small community, but you really see that when you get into larger communities where maybe you have two different hospitals and they each have their own physician groups. And if you see a physician leave one group and go to the other group, the patients don't tend to stay with the hospital. They tend to follow the physician and change hospitals, unless, of course, they have insurance coverage issues, other things that prevent them from being able to make that kind of a change. So these physicians now going into the future are going to be important because they are going to drive not just the volume of the service, but if we're in an ACO where we're going to get paid based on covered lives, they're going to be the ones that are going to control where those covered lives go and where that revenue stream is going. And it's going to be even more important with primary care versus specialty care, because primary care physicians are going to capture and own that market. So, as we look at improving these relationships, what are the things that we have to look at? And this is a whole different monster than what it was 10, 15 years ago, even 5 years ago. To improve these relationships, we have to have an alignment of vision. Are we trying to get to the same place? Are we trying to go in the same direction? And so as we look at this, we have to work on the confidence and trust between the two. We have to look for physician input. We have to have champions. We have to talk about what kind of feedback do they get. We have to look at accountability, requisition, and rewards, and then finally getting to that aligned vision. So let's talk about what those look like. First of all, communication. Communication in any business is extremely important. But as soon as there starts to become a breakdown of communication between administration and physicians, there begins to be distrust. And it goes both ways, but we need to be making sure that we have good paths of communication good avenues of making sure that information is being shared freely and appropriately back and forth to prevent that distrust from growing. I always think it's important to realize how much time we spend, especially if we're looking at trying to recruit these physicians to our communities, how much time we spend at the early stages of courting them and trying to get them to buy into the fact that they need to come to our community. And then as soon as they get there, we kind of shut down the communication, and we don't always treat them as well as we should, even though we just got done courting them. Communication can help continue that process that we had when we were trying to get them to come to our community, to continue to build upon that relationship. One great place to start is in the area of board involvement. And so when we look at board involvement, the question I often have with a provider is, do you have a physician on your board? And sometimes it isn't allowed. Maybe it's a governmental and it's all elected officials in positions and things like that. But then it's at least somebody who's there on a regular basis to provide input to the board and discussion at each board meeting. And what this really does is it promotes that discussion on those issues that are important to the physicians. It could be compensation issues, it could be equipment, it could be building, it could be services, it could be who knows what it's going to be. But at the end of the day, what it does is it allows that discussion to float up to the top at the top level of the organization and try to promote that positive discussion, making sure that their issues and concerns are being addressed somewhere throughout the organization. We also have to look at physician input. And now, as I talk about this, the important part is that I'm not trying to say that physicians make all the decisions. But what we're looking at here is that if you need to pull in that whole issue of that they need to be involved in significant issues that pertain to them, new service additions, deletions, other types of program changes that you're looking at. And what that does is it helps create and enhance this vision, this aligned vision that we're going in the same direction. We understand what they're trying to get at, they understand what we're trying to get at, and we can work on solutions and decisions together that promote both sides of the equation. A lot of times what this does is you'll end up with the creation of what they call decision flow charts. And what a decision flow chart does is it lays out how you're going to handle certain types of issues. Will the physicians have input? If they have input, what level of decision making do they have? Is it just, they get to make the decision on these things? Is it that they get to make recommendations? Is it some sort of a joint methodology? And so, kind of looking at that whole process of how do we make decisions. And when you do this on the front end, it solves a lot of problems on the back end because the decision's already made as to how it will be handled. Because a lot of times the arguments come into play is, well, no, we should get to have this decision, and no, you shouldn't, and it goes to a back and forth kind of a battle. Physician champions. We need to figure out who is that physician champion. This champion is that person who understands the value of both sides of the relationship, the hospital side, the physician side, and comes in with the ability not to only understand it, but has the ability to be an influencer, is looked up upon by the other providers, because that's the first person you have to sell when you're looking at doing change or moving things in a new direction and getting the pulse. This one really helps you have somebody that can promote to the other physicians why you're doing something, why you've taken a specific position on a certain item. It really gives that strength in that area. And then physicians, as you're looking at trying to build this aligned vision, you need to understand what kind of input they want or feedback they want and the timing of that. They expect decisions to be made quickly. So when we say expect timely decisions, we mean like now. And the reason that happens is that for a lot of the physicians still, we may see some of this change in the future, but most physicians at some point in time had their own practice. And in their own practice, they were able to identify an issue, determine what the solution was going to be, make the decision, and the action would begin. Hospitals operate the exact opposite. We have tons of committees, we have teams, groups, committees, all kinds of things going on that tend to slow down that ability to make a decision, and that frustrates physicians. So we need to work with our physicians as to what is the expectation going to be for different types of decisions so that we can meet their expectations in that arena and still continue to maintain that positive relationship with them. Shared levels of accountability. And what we look at here is like a physician or provider compact. These are things of this is what we as physicians expect from the hospital. And on the flip side, this is what we as a hospital expect from our physicians. And I've just seen a couple of neat ones recently where they actually have it posted in their organization. And it talks about how they expect to respect each other, how they expect this, people will take care of things financially and timely and everything else to try to promote what we're trying to get at and who's going to be accountable for which pieces. You need to set expectations, financial and otherwise. I always think when we look at from a financial perspective, again, when we spend so much time trying to bring in physicians, and then as they get started in our practices, and we realize that most often they're losing money in their clinics, we send them reports every month beating them up because they lost money again, even though that was the expectation when they came in because most clinics don't make money. So from a financial expectation, maybe when they were coming in, we should have realized that, you know what, on average, we're going to lose $5,000 a month on this doctor. Whatever that dollar amount is, 10 depends on the market you're in. But then that's what we measure to. If we lose less than what we expected, we celebrate. And that's a real hard comment to come from somebody like myself who used to be a CFO, because we're like, well, what do you mean I'm going to lose money on it? Well, the reality is we do on some things. So we set the right expectation, measure from there, celebrate the successes, work on those things where we fall short. And then ultimately, at the end of the day, we hold the accountability. We also have to be looking at, the tools and processes to enhance productivity. Oftentimes in our organizations, we do an awful lot of things when we have physician relationships that are, the effect is basically to slow down the physician's ability to get things done. It's interruptions, it's poor scheduling, it's bad systems. We can go down the whole line of what they are. What we need to be looking at doing is what can we do to help streamline processes for them in their clinics, in their operations, in our interruptions, whatever it is. So ultimately, we improve their productivity. We improve their productivity, we tend to improve their bottom line, their pocketbooks, and now we've got physicians that are starting to get on board with us because it's not just about us, it's also about them. How do we help make those things happen for them so that they can have a better end result? And then recognition and rewards. And this is not just compensation. Everybody thinks that, recognition and rewards is going to have a dollar sign attached to it. And it really doesn't. It can be as easy as recognitions on newsletters of, hey, this is what so-and-so did, congratulations. Dr. So-and-so did this, congratulations on that. It also can come down to making sure that we're getting them out and giving them professional leadership development. We tend to be really good about sending our hospital C-suite staff to leadership training. But, our physicians are also leaders. And are they getting that training from us? Are we helping them understand what's going on in the industry and what do we need to be looking at from a professional development perspective? Their education here, being non-clinical types of education oftentimes, is just as important as it is for the rest of the organization. And it allows time for the groups to grow together as they're working in that arena. So that kind of takes us out of that physician side. Really important because, again, they are going to drive the covered lives, which is going to drive reimbursement over time. Now we're going to get into talking about volumes, because volumes also, again, can drive up the revenues, drive up the bottom line. So we're going to look at volumes a little different. In the past, if you were to look at an organization, successful organizations were oftentimes those that would bring in a patient, attract a single patient in, and figure out how to provide as many of the various services that they can render to that patient in the shortest amount of time. That would drive up gross revenues, drive up profits. So as we look in the future, if we want to maintain our volumes in a value world, that's going to pay, because in a value world, they're going to pay us for doing less services or doing the same services for less dollar amounts. If we're going to maintain the same volumes, the key here is we're going to have to go find more lives. We're going to have to find more lives covered by reimbursement and provide the minimum number of services possible to them, which will demonstrate value while still making sure that they get the quality. So that is going to be the new volumes. How do I figure out to attract more of the market versus how do I do more things to the current people that I have here? So in the future, cost of population health is going to be the most important piece of it, which means we're going to have to change the way we look at things and start focusing more on what is my market share in the various services that we're offering and what are we doing with that. Oh, how are we going to figure out the market share? Three great areas to talk about here. We're going to talk about the community health needs assessment, understanding your market share, and then understanding future market needs. So, community health needs assessment. For those of you that have not done one, this provides a vital information to help you to determine some things and some steps that maybe you can do to enhance your market share. May also identify some areas where you have risks. Now, not every organization is required to do a community health needs assessment. If you are a 501c3 facility, absolutely you have to be doing that. Governmentals don't have to do this. But what we recommend is even if you're a governmental and not required to do one, this makes good sense. So oftentimes when we get a government mandate, we kind of push back saying it's just a waste of time, why am I doing this, etc. This is a really neat opportunity for your organization to find out a lot of information about your organization, from what they're feeling, what they have and what they like, what they don't like. You're going to find good things about your organizations as you're going through here. And most importantly, you're going to find things out about your organization that maybe you didn't want to know, but you really did need to know. Areas where a service is maybe not perceived to be appropriate, adequate, of proper quality. I don't want to hear that. But as an organization, I need to hear that, because by changing that perception, I can change potentially my volumes. So not just a legal requirement, but really an opportunity to learn a lot about your organization. So when you look at this here, you get the community health needs assessment. Now you need to be developing your strategic plan around that. What are we going to do from that, what we learned in the community health needs assessment, to help enhance our organization and what we provide to the community? So it could be, what services are we going to make sure to get into the community? Now, that doesn't mean we have to bring those services in and do them ourselves. Maybe we're going to have an outside entity that we work with collaboratively, so that they actually bring in the service, but it's keeping people in our local communities, which is so very important with rural. The more we can keep them in our local community, the better ability we have to capture those things that they need. And even if you don't build it your own, just by being the one that helps bring it in, it shows that you have a sense of being connected with your community. You're part of it. You're trying to help find solutions, even if they're not you. So now you put together this strategic plan based on this community health needs assessment, and then the biggest piece is we need to have some sort of reporting on it. Too often we find out that organizations look at this on an annual basis. They go back and say, it's time to redo our strategic plan. They dust off the last one and start looking at, well, how did we do on that? If you measure it once a year, you're probably not going to be doing real well. But if it's part of your regular board meetings, your ongoing reporting back as to what activities are we doing to make things happen, that's when things are going to change. And again, remember, the whole important piece here is we want to increase the number of covered lives. That market share that might be leaving, we want to capture them in our community, maybe even attract them from some of the outlying communities if we're in a rural area, so that we keep as many services local as possible, as well as appropriate. So let's go to market share. Providers need to understand what this market share is, and what we're looking at is what percentage of the market share are you capturing. So that's one important piece. Probably the most important piece to me is who's capturing the market share that you're not capturing. So is it another small rural hospital in your neighborhood, or is it a larger tertiary facility? So that's getting into, who is getting it, and then from there you start drilling down to the whys. Why is somebody going somewhere else? Now, some of this you may identify from the community health needs assessment, but there's a lot of other things that you may be able to identify through discussions or additional research. Are you losing people because of quality? Now, oftentimes it may not be really that the quality is poor, but maybe there's a perception that the quality is poor. And now the challenge is how do we change that perception? What do we need to do differently? Is it a physician preference? I know in some organizations I've had, they'll say if I have, like in the emergency room, if we have Dr. Y in the emergency room that weekend, we don't have anybody because people don't care for that physician's demeanor, etc. So now what are we looking at doing there? On the flip side, maybe when Dr. Z is there, everybody's coming. You might lose market share because of location. Maybe it's hours of service. In today's world, having things open from 8 to 5 doesn't always work anymore. And then also the last piece that I always find concerning and interesting is just awareness. In the community health needs assessment, oftentimes we'll find that people are going elsewhere for a service we provide because they weren't aware that we provided that service. And that might be the case even though we've done a lot of advertising on it. Maybe we're not advertising in the right venue, the right marketplace. So how do we get to that point of understanding our market share? The other thing we've got to look at when we're looking at market share, that tells us where we're at today. We need to understand what's going to happen in our market in the future. So now we have to start looking at population trends and, also service line trends, be it inpatient or be it outpatient kinds of things. So we need to understand those components. So population trends would be looking at, what kind of predictive models can you access that will give you an idea of what's happening as far as population in a community or in a service area. So you can break this down into the subsections of your market. To the east of us, that area is going to grow. To the west of it, it's going to decrease. Maybe it's going to maintain to the north of us. We can start looking at, where do we want to be looking at adding services or enhancing our service lines based on what's going to go up and down in the total populations. And we can also then look at what's expected to change as far as the age of the patients, because we know as patients age, they have different services that they require. Sex, male, female split. What is going on with that? Because will that change what we need to be looking at adding or decreasing within our service lines? Ethnicity. Certain ethnic groups have different types of health issues and challenges just due to the genetics. So now we can start looking at, what other services do we need to be putting into place, or again, maybe pulling back on based on changes in our marketplace during those time periods. You also then can look at inpatient service trends. And what this looks at is, what is expected by each service line going forward. We know things are changing as far as certain types of services, and you can look at this for 5 to 10 years out, and it gives you volumes or anticipated volumes for all providers or for those patients in that community. So here's an example. I know it's a small sample or a small graph here, but what this looks at here is it's starting with cardiac services and going down and saying, okay, between 2013, 18, and 23, here's the volumes we have inpatients for cardiac, ENT, general medicine, general surgery, and you can take that all the way down, and on the right-hand side, you can see what's the overall growth anticipated in 5 years or in 10 years. And as you can see in this graph, most of the numbers on the right-hand side are in red, which is saying we're going to see decreased inpatient trends in these areas in the next 5 to 10 years, which would make sense because we all know that we are seeing huge changes in our inpatient volumes, have for years, but it's becoming more and more where the service can be taken care of in an outpatient setting. So if somebody here was saying, gee, I think I want to add some services in the area of vascular services, and you can look at, boy, in the next 10 years, the very bottom right-hand corner, that's actually going to decrease in patient volumes 25% in the next 10 years. Probably not an area that I want to invest in. If I'm going to look at trying to drive some inpatient volume, it might make much more sense to look at something like neurosurgery, although the volumes are really low. inpatient probably in general doesn't make sense to be focusing on as the bread and butter of the future. You can also do similar types of looks on the outpatient side. Again, looking by service line, showing the 5 to 10 years. These numbers I think are very interesting because as we go down and look at these numbers, same type of a table, you can see on the right-hand side a lot more green. Now we are definitely going to have some services that are going to decrease, but there's a lot more in the outpatient arena that are going to increase here. You know, you can see there's endocrinology, neuro, surgery, oncology, physical therapy, rehabilitation, some big areas. If this was your market area, those would be the areas you would want to focus on, saying, I need to enhance my service line to prepare myself for this future volume as it starts to come down the road. Next, we'll get into the revenue cycle. Changes in the industry have increased the challenges of the revenue cycle. We all know that. We see such a huge change in the revenue cycle because of the fact of higher deductibles, higher copays, more patient responsibility. So they're shopping around a lot more. And when they do come in, they have a lot more out-of-pocket they have to come up with. So the challenges in the business office and revenue cycle have become much more difficult. So strategies. The biggest thing in the area of revenue cycle, I would say when you're trying to figure out how you're going to drive some better bottom line is you have to work on the establishment and adherence of policies and procedures. I would say half the facilities I go into, smaller rural providers, have outdated policies. And then when they do have current policies, they're not adhered to very well. They're not adhered to by the staff, and they're often overridden by management. And what we need to have is we have to have strong, consistent policies if we want to have strong, consistent results. We need to be improving the quality of documentation and coding. Oftentimes in the critical access hospital world, we have a lot of individuals that say, well, we don't really worry a whole lot about our documentation and coding because we get paid cost. Well, that's true, but there's some real reasons why we need to start looking at the quality of the documentation when we're trying to prove quality. We need to maximize the use of technology so that we make the systems do more of the work. Things like not posting payments manually when they can get a electronic download and do it automatically, so we can focus our time on more important things. And finally, we need to keep driving down the days in accounts receivable. So where are we going to start? Upfront processes. Excuse me. When I go to talking to this piece, I can tell you when I started in healthcare as a CFO 24 years ago, if I would have brought this process up as a step that we need to do in our organization, I would have probably been thrown out the door because nobody was collecting money at the time of service or prior to the service at that point in time. However, because of all the changes in the industry, the higher copays, higher deductibles, increasing mobility of patients. Patient might be here today, but we don't know they live here. They may be just passing through. People change jobs so fast. We also see large changes in the number of health insurance carriers. That's because employers are looking at different options, so they're changing insurance companies more often. We have access for some of us on the marketplace. So we're making our own decisions to change insurance companies. So a lot more importance is making sure that we know what's going on the front end of the process so that we can collect the financial resources necessary to continue to operate our organization. And what I can tell you is as we go across the country in small rural areas, there's significant variances in how this is handled. We have some organizations that are very stringent about getting information up front and having discussions with their patients about financial pieces. And we have some that will not do any discussion up front and worry about trying to collect things on the back end. And I can tell you that over time, you can really see the difference between those organizations on the financial performance. So, first piece, identifying and responsibility. It's really hard to, this is a no-brainer comment, I guess. It's hard to collect if you don't properly identify the patient. And what we mean by that is that there really is a reason why you have to get the photo identification and insurance cards and insurance verification while they're there. And each and every one of us has probably had that situation where we're going into the hospital or whatever healthcare place we frequent, and it's the second or third time in a very short time period, and we get asked for our IDs and our insurance cards, and they're going to verify everything again, and we get frustrated. Well, if we go back to the fact that there's increased mobility, changes going on all the time on insurance cards, the address that we live at can change quickly. The insurance company we have can change frequently. The coverage we have under our insurance can change frequently. We have to be capturing that information. And that's not always an easy piece at the front end of the organization to be asking for. A lot of times it's because the people have been trained to explain why they need to capture it each time. So you have to have processes in place, and then you have to have accountability. And this is even after hours. After hours is probably the greatest challenge in a hospital system. They may be able to get this down from the hours of 8 to 5, but outside of that, we may not always have dedicated full-time admissions folks that are in that process to capture that. It could be nurses, it could be aides, who knows who's going to be doing that capture, but we have to hold them accountable to capture the same information if we want to hold anybody accountable for ever capturing that revenue and collecting that revenue at the end of the day. At the same time you start doing the upfront collection pieces, you can identify coinsurance, deductibles, etc. What really is nice is if you can give them estimates ahead of time. If you can get an estimate ahead of time, you can start working about how they're going to pay for that prior to the time that they have the service. And they're always much more apt to have good conversations with you ahead of time. They may give you credit cards, they may give you down payments, all kinds of things that you'll have to chase down later after the fact. They also like estimates because it makes them feel more comfortable. We all don't like that unknown of wondering how much is that bill going to be when it shows up. If we know on the front end there's a lot of reports out there that patients actually do better when they don't have that stress of the unknown of what that bill is going to be. We can do estimates for non-scheduled. I have some entities that will X dollars for a CT, X dollars for an ER visit, X dollars for lab. That's just the estimate if they don't have the ability to get down to the coinsurance deductibles and everything for each individual insurance company. We can also help them when we estimate it to collect it. We can identify loan sources. More and more facilities are working with banks and other creditors to help come up with ways to loan the money to these individuals so that we don't end up becoming the bank as an entity, because we don't have the ability to finance everybody with the higher deductibles and co-pays, etc. For those that qualify, we can establish payment plans, let them understand what that means, how it works, what happens if there's late payments, etc. And all of these things include every place you do services, even in the emergency room, if it's non-emergent. After triage, if it's non-emergent, you can have these conversations and help them understand what their liability is going to be, and help them identify methodologies to help pay for these things. If you have the right processes in place, you can also start trying to identify charity care patients on the front end. There's nothing worse to find out that somebody's been trying to collect an account for months, only to find out that they were a charity care and we should have known that on the front end. If they don't have anything, you're not going to collect anything. So let's identify that up front. And these can be done through normal applications where they typically bring in payment stubs or paycheck stubs. They'll bring in copies of a tax return, things like that. We also now have some people that are using presumptive methods. And this sounds a lot like Big Brother, but it's as you're doing the admissions process, it takes that information, pulls things up, and can identify estimated income, family size, etc. of this individual from various data sources out on the web, the internet, and give you a good idea of, does this person qualify for charity care? And you can actually speed up that process and just kind of begin to move forward. And the other thing is you look at the identification of charity care or coinsurance and deductibles, etc. is sometimes you can help reschedule services, because they may say, you know what, that's not what I want to spend. I want to think about it. I want to, maybe do it in a different venue, whatever, where my pricing is going to be different. But at least you have all those discussions on the front end. Also provides a lot of patient satisfaction. The back end, this is the collection side. Those self-pay balances after insurance gets done. We have to have solid policies, payment plans, collection agencies. Make sure you understand how good your collection agency is. So often facilities hire a collection agency because they charge less as a percentage for collection. Well, that's only one part of the calculation. You want to know how much are they going to collect in the first place. Because if it's a low rate, but they only cherry pick all the easy accounts and leave all the difficult accounts, are you really getting ahead? Or do you want a collection agency that'll just really work hard for you? The rate might be a little higher, but they're going to collect a lot more dollars, and at the end of the day, the net is going to be an improvement to you as your organization. And then we have to make sure we just follow all of those policies. None of it does us any good if we're not following the policies. Charge capture, best practice facilities out there, if you're going to really try to make sure you're going to have a bottom line, is you need to capture the services or the charges for the services you render. And that sounds like it should be simple, but it's really difficult in the hospital setting, especially in outpatient area. And this isn't even for small facilities. This is the same issue we see in large entities. Most common areas are outpatient nursing and pharmacy. Outpatient nursing, again, it's all size facilities, but it's things like IV therapy, injections, Foley cath. Anything that nursing does outpatient is an area of opportunity most often for additional charge capture and reimbursement in the organization. The reason that IVs and things like that are difficult is sometimes we're not holding people accountable for the documentation. Nursing documentation in this area is probably the hardest part, because you have to have start time, stop time, site, drugs, all those things. In EHRs, sometimes they will help you with that electronic health record. Sometimes they're not even built to properly capture that. So we need to make sure that they're capturing all those dollars. Typically, this ends up being a nursing team with an HIM team, and they can drive the results. There can be some significant dollars here. Pharmacy is another area where this can be a real challenge. It can be charges totally missing, or they're reporting the wrong number of units. Totally missing is because people rely on dispensing units, Omnicells, Pyxis systems, etc., that they say will help you capture your charges. But it's really easy to circumvent the controls around those, and oftentimes if people aren't monitoring that, we find out that they're giving out a lot of drugs in meds that are not being properly captured. The unit issue is the fact that hospitals have to report their drugs using HCPCS. These are alphanumeric codes that tell you what the drugs are, but the units in those definitions are often different than the units that you actually prescribe because they don't match up. So you have to have multipliers, and organizations really struggle on getting that corrected. But definitely an opportunity to help drive some of those revenues, which is going to help us have better financial dollars and financial statistics. So as we start beginning to look at that transition into the healthcare world of the future in reform. Documentation, coding. This is important for everybody. As I indicated a little bit earlier, it's not just a PPS issue or somebody who's paid on fee schedules. Every time we document something, we put it in there, those ICD-9, soon to be ICD-10 codes, the CPT codes, the charges, what they all tell the world is how complicated was our patient and how much did we charge them for that level of complication. If we're not capturing everything on the claims to tell them how difficult our patients are, it could appear that they're paying a lot more money for patients who really aren't that sick. And in a value-based methodology, that's going to cripple rural providers, critical access as well as PPS. Pricing, we also want to monitor pricing, make sure we know where we're at there. None of what I'm talking about here should be confused with gouging of pricing, but maybe adequacy of pricing, just making sure that you're not behind the market. And while in rural markets, and I was a small town hospital CFO, while in rural markets, we're used to paying a little premium for some of the things that we pick up at the grocery store, the five and dime, the hardware store, some of those things. We understand we're paying a little extra because of volume and the cost of business. Hospitals, on the other hand, tend to be the exact opposite. Most of the time, we find that they're significantly lower priced than their competitors in the larger markets. And some of this goes back to when they became critical access, this whole issue about, well, we get paid cost, it doesn't matter. And there's all kinds of reasons why it happens. It can be board saying, we're not going to increase prices because we get beat up in the public, lack of understanding, and the inability just to even have market data. So facilities that really want to understand this well, get market data. You can get commercial data. I actually like MedCard data. It's outpatient claims that were sent to Medicare. And you can get pricing for things. Mostly it's going to be a lot of outpatient type services, but it gives you some good pricing comparisons for the market you want to compare to. You want to be somewhere between 50th and 75th percentile of the pricing. I like the 75th. The reason I don't like the 50th so much is that the average facility is struggling financially. Why would we benchmark there? And finally, we have to have some annual updates to all this pricing. And then timely filing. We get all these claims, we get them all captured, we get the pricing right and everything else, and then we don't send them in on time. Medicare allows us 1 year. That's a long time, but we have a lot of facilities that we run into that write things off because they didn't get their bill in on time. Other payers are changing. A lot of commercial payers now are at 90 days. Those payers, we see a lot of facilities writing dollars off because they don't get their billing on time. I've even seen one recent contract where the payer tried to get it in 30 days. That would be a huge write-off for a lot of organizations. So why are they missing these deadlines? They got to look at their processes, monitor the write-offs, and make sure that they're fixing things moving forward. It's going to be important today as well as in tomorrow. Denials management. Denials management, we're looking at advanced beneficiary notices, often known as ABNs. And what we're looking at here is, you know, Medicare requires these if Medicare isn't going to cover something, so we can tell the patient they're going to be responsible for the service. So they're not an option. It's a huge compliance thing, although we see a lot of providers that are not using them. It is a requirement. And the biggest piece here is to understand that what we're trying to figure out is who's going to be paying the bill. Not is it good care or bad care, because there might be a lot of good things a physician wants to do that the Medicare just is not going to pay for. So we're going to track denials in this area because we don't want a lot of write-offs, although I have a lot of organizations that have write-offs. Lab used to be the big area. It still can be, but we're seeing a lot more issues in the area of imaging, CTs, MRIs. It doesn't take too many of those to make some big changes. And then the emergency room area for these organizations also needs to be watched for ABNs. You may not give out an ABN there because you're worried about EMTALA, and I can agree with that. But if you see a large number of items that are written off because they didn't meet medical necessity in the emergency room, we can at least have the discussion with the providers as to why are we seeing this? Is there something we can do from a practice pattern change to make things work a little better? So that takes us to the first half of the strategy pieces. We'll talk a lot more about expenses and other things on Friday. But right now, we've got about 7 minutes. It looks like we can open up the lines to some questions.
Thanks, Ralph. Looks like Jill Bullock has a question. Where rural areas are so rural and have an extremely hard time recruiting physicians, how does the facility work around population trends to meet the community's needs?
Well, I think there's a couple things. One is, it's not easy, okay? That's the first thing we need to say. When you get in really, really rural areas, those administrators, they're working hard. You know, they've got their work cut out for them. But what we need to look at is first focusing on primary care, make sure that we do what we can do to get the primary care piece in there. When we start looking at some of those other trends of where they need specialty services, that's when we can start looking at visiting specialists. What can we do to get visiting specialists out there by working with some of our facilities that we have alliances with or agreements with? You know, be it a, you know, maybe it's a psychiatrist, maybe it's a general surgeon, maybe it's, you know, who knows what it would be for each facility. Could be a little different based on their trend. The other part that we have to keep watching is telemedicine. Telemedicine, I think, is still an extremely underused issue. It's not all the providers' faults, though, but a lot of it's a reimbursement issue. But what we need to be looking at there is pushing Congress and CMS to better fund telemedicine, because the things that we can do from a telemedicine perspective to intervene earlier in the needs of the patients can help save a lot of other costs down the road. If we catch something early, we may not have to pay for an inpatient stay, or CMS won't have to pay for an inpatient stay. We may be able to avoid ambulance transfers. There's so many things there. Telemedicine, we have to keep monitoring what is allowable and start engaging in that area, knowing at the same time we have to keep pushing Congress to and CMS to improve the payment. Because right now the payment is $24 and some odd cents. And that just doesn't cover the cost on the originating site side. We are definitely getting some attention by some congressional leaders for that, but that is really where you're going to have to start looking at it. There's going to be a lot more telemedicine being done over time.
Thanks, Ralph. Does anyone else have any questions? Oh, it looks like Arizona has passed the telemedicine parity law. The problem is having a physician on the other end.
You know, I'm not exactly totally familiar with the Arizona law.